So thanks for having us. I'm Alex Hall, assistant professor at Emory University in emergency medicine and part of the ENRICH clinical trial scientific leadership team. And we designed and executed this trial. Along with me here today is Dr. Jonathan Ratcliff.
Hi there.
And Dr. Gustavo Pradilla. Dr. Pradilla is our surgical lead investigator, and Dr. Ratcliff is our neurocritical care lead investigator. So the ENRICH trial was designed about 7 years ago to look at minimally invasive parafascicular evacuation of intracerebral hemorrhages, with our primary location group being the lobar and basal ganglia population. And what we were trying to determine was this type of approach and evacuation beneficial to patients on the 180-day modified Rankin Scale?
The study was designed to evaluate intracerebral hemorrhages in two anatomical locations. One was the lobar hemorrhages that reached the cortical surface, and the other one was what we determined as the anterior basal ganglia, which included the caudate, the putamen, and the subcortical structures up to the external capsule, so those deep anterior hemorrhages. And the study randomized 1-to-1 with the comparison group being medical management. The surgical treatment consisted of a standardized approach and a standardized technology. The approach required what we call frameless stereotactic neuronavigation, where a CT angiogram that was used during screening was then loaded to a neuronavigation system to provide guidance for the point of access and the target, and the trajectories that were selected to access these clots were based on the least disruptive trajectories to the long axis of the white matter fibers, which is relatively a new concept in terms of surgical access for these types of lesions, being more respectful of the subcortical white matter. The second component of that was using a device that is tubular in nature, has a small footprint, and it allows us to provide good access and visualization while minimizing trauma to the surrounding brain. And that device is called the brain path. And then the third technology we use is an automated resection tool that allows us to suction and morselize the clot in an efficient way to increase the amount of clot that we're able to remove during the intervention. The visualization was also a special type of surgical visualization that at the time of the study design was fairly new, and that's called exoscopic visualization, where we use high-resolution cameras that are placed at a certain distance from the target that can deliver sufficient light of magnification to achieve a high-quality surgical environment at the bottom of these small minimal access ports in deep locations in the brain. So that's what the procedure was. And this intervention, we designed in the protocol to be done within 24 hours of the last known normal of the patient. And we strive to intervene surgically at least within 8 hours of last known normal. And with that in mind, we had 37 centers in the U.S. that participated in the trial.
And I think, to summarize that, the reason why we thought that this was the ideal surgical procedure for ICH was its ability to have an immediate impact on mass effect, maximize our ability to have clot removal, and minimize other iatrogenic injury. So the combination of all of the features of the technology allowed us to achieve that achieve those goals. So the trial overall was multi-center, randomized, and adaptive, comparing the two groups, the sort of routine medical management versus the surgical management using MIPS. And ultimately, we're trying to provide that clinical evidence of functional benefit, as well as ensuring that safety was maintained throughout the entire cohort or both groups. So all of our patients were block randomized by either their initial index GCS and by their location. We had a planned sample size of 150 to 300 patients, starting at 150 patients, and then every 25 after that, there was a interim analysis conducted to determine if we should enrich. The primary inclusion criteria was an age between 18 and 80, a primary spontaneous ICH, a GCS between 5 and 14, a hemorrhage volume between 30 and 80 cc's. As Gustavo mentioned, intervention being able to be initiated within 24 hours, and a pre-study or historical MRS of 0 or 1. Some of the main exclusion criteria of our trial was any other secondary cause of hemorrhage, such as aneurysm, AVM, et cetera, a very low NIH stroke scale, or a clinically well-appearing patient. So if the hemorrhage occupied greater than 50% of either of the lateral ventricles, or if there was any herniation or brainstem type clinical findings, and if they had any uncorrected coagulopathies or anticoagulants that couldn't be rapidly reversed. So our primary efficacy endpoint was the mean utility weighted MRS at 180 days. So our efficacy outcome was the modified Rankin Scale score, and we used the utility weights to perform our Bayesian analysis. The success based on our pre-specified criteria was a posterior probability of greater than 97.5%. Our outcomes, the MRS, were all adjudicated by an independent neuropsychologist who was blinded to the treatment arm. And so she listened to audio recordings and adjudicated the MRS outcomes. Overall, we screened a little over 11,000 patients across those 37 centers. The majority of them were excluded because they didn't have the right type of hemorrhage, or were in the wrong location, or were in ischemic stroke or whatever. 300 in total were randomized, 150 to the MIPS group and 150 to the medical management group. And enrichment occurred after 175. And so our primary adaptive trial enriched to only include the lobar locations after 175 patients. The mean age for everyone randomized was 62 in the MIPS group and 61 in the medical management group. We were well balanced otherwise across all of our other baseline characteristics. And our primary efficacy endpoint was the posterior distribution of that treatment effect, which was positive both in the pooled and the lobar group, with the lobar being 0.9968. And so in this trial, we can claim superiority of MIPS in the lobar group. And that was some of the main findings we presented at ESOC. Jonathan, I can go over some of our secondary outcomes that we covered at ESOC, and then sort of answer any other questions.
Yeah, great. Thanks, Alex. So one of the things that we saw with this and planned to do analysis on was the MRS at a variety of different endpoints, or time points rather, to see if the beneficial effects of the procedure was at what time point did that begin to differentiate? And so we did an MRS at 7 days or discharge, whichever came first. And that, on planned ordinal logistic regression analysis, showed a protective effect mostly with decreasing the number of deaths and decreasing the MRS-5s, and that was statistically significant. In addition to that, the MRS at 30 and 90 days also were statistically significant on ordinal logistic regression, making this so that throughout the course of the patient's stay, or the post-treatment effect was seen rather early. In addition to this, one of our goals was to get as much blood out as we possibly could, and the procedure did very well at removing blood, and the median end of treatment volume was about 7 mLs with an interquartile range of 1.95 to 17.34. The interesting piece of that is that when you look at that from the standpoint of how did that affect outcome, it was associated with the greater the removal of hemorrhage, the better the patient did, again on a planned logistic regression. From a safety standpoint, one of our primary points of interest was what happens at 30 days in relationship to death. And in the medically managed group, the death at 30 days was about 18.1%, while in the MIPS group, it was only 9.3%. And this was also a statistically significant difference. In addition to this, though, we noticed that the ICU length of stay was shortened by about 2.6 days, and the overall hospital length of stay was shortened by a little over 2 days as well. So ultimately, what we see is that in many of the clinical parameters that we were interested in before the study began, that the MIPS group did better, and also the biologic plausibility that we were looking for in terms of the amount of hemorrhage removal that was conducted was associated with the primary outcome. So in that way, we feel like we have biologic probability, or we've observed biological plausibility and also seen positive effects throughout the course of the patient's care.
Yeah, so I think, one thing that we can speak about is we're certainly not the first people to think that surgery for ICH could be beneficial. There's obviously several other of our colleagues in the field that have looked at this over decades. And I think as technology improves and as clinical trial design improves and patient selection improves, we start to figure out our path. We kind of saw this across the board with a lot of the thrombectomy trials, and having that experience and knowledge base of sort of how endovascular therapy worked really is what tailored a lot of our thoughts and designs with the ENRICH trial. And to date, this is really the first clinical trial to demonstrate that functional benefit of surgical clot evacuation. Even though there were some signals and other things seen in other trials and secondary outcomes and stuff like Stitch and Misty, we were really able to hone our design and population into something that we thought would be beneficial, and we're happy to actually see that happen. I think it doesn't close the book on the questions around surgical clot evacuation, and certainly different locations and different disease types. I think what we're most excited about is it really opens the door to a lot of other possibilities that can exist in the future to find those right interventions for the ICH population. I'm sure Gustavo and John had other comments on this as well, especially in the surgical field realm.
Hemorrhages were dramatically responding to the intervention. There was no question about that. For basal ganglia patients, we certainly had patients that benefited in the study and did very well, but we also had patients that did not. And that population landed right about the middle in our analysis. So the basal ganglia location remains an open question. And there are things that we are analyzing now to try to understand how to refine that population better. Some may have to do with timing. Others have to do with volume. Our overall volume parameters were 30 to 80 milliliters. And lower locations can tolerate that upper range fairly well, especially older patients with brain atrophy can tolerate 80, sometimes 100 cc's without having a life-threatening event and achieving good outcomes. Conversely, basal ganglia patients that have 80 cc's, they really struggle. So I think the upper boundary for basal ganglia may need to be a bit lower. And the other part has to do with outcome measures. We may need outcome measures that are specifically targeted to the basal ganglia. The impact of those hemorrhages on the internal capsule and on motor fibers, specifically what it does to the density of the corticospinal tract over time and the ability to achieve motor recovery is something that would like to understand better. For dominant hemisphere patients with basal ganglia locations, the impact of this on speech is important. And for those that affect the medial part of the caudate and putamen that have behavioral and volitional challenges similar to an anterior choroidal stroke, for example, those also will require different types of outcome measures to determine improvement. So we need to refine that. I think one of the really differentiating features when you look at this technique versus what was done in the MISTY study is that we included patients that had a positive spot sign, patients that had active bleeding in their CT angiogram. And we were able to deal with that in a very effective way. And that was one of the exclusion criteria for the MISTY approach. So that's an important part. In the newer methods that are being tested in ongoing trials that use endoscopic evacuation, the ability to visualize the cavity and to achieve hemostasis with an active vessel can be challenging. And several of those ongoing studies that are using an endoscopic approach have spot signs as an exclusion criteria and require a stability scan to ensure that they will not encounter active bleeding during the evacuation. So those are things that we are taking into consideration as we approach our next steps and we think about what will be an applicable technique to treat basal ganglia patients. Then the other population that we had an interesting experience in the past doing some of our preliminary work was thalamic hemorrhages, which are, of course, a substantial portion of these deep hemorrhages. And they're very accessible with this methodology. For our trial, when we looked at the rates of recovery and the timelines to achieving comparable outcomes, thalamic hemorrhages typically took longer. These patients tended to be intubated for longer periods of time. They have more substantial midbrain involvement, and that delays many of the parameters we use for success. They remain intubated for longer periods of time, which keeps them in the ICU for more days, and to achieve a comparable modified Rankin score would take longer. So that's why we did not include those. But that is a population that I think is primed as another location to investigate if this approach is beneficial. And I think one of the critical parts of the study is that we use devices that are FDA cleared. And the technology that we use has been used in thousands of neurosurgical procedures, many for ICH, but also it's something that is used to access deep brain tumors, lesions in the ventricular space, biopsies. It has many other applications. So it had a presence within the neurosurgical armamentarium, and it was a known entity. It was particularly well suited for ICH for the reasons that we mentioned earlier. Another important thing about our trial has to do with our sites. when you look at the 37 sites, we had many of the leading academic institutions in the country, but we also had large and medium-sized community hospitals. And when we looked at the surgical performance in terms of level of complexity, surgical experience, we saw that the procedure was well done, well executed, and with good results in all of those different settings. And I think the implications for that and the intent when we selected this procedure for ICH was that this is something that can be done in any community hospital that has the technology and has received the proper training. It's not something that necessarily has to be done in a tertiary care center. And that's an important part of this because as most of cerebrovascular pathologies, this is something that we think has a time implication where intervention as soon as possible can make a difference in terms of survival, in terms of neurological outcomes. And when we look at all of these secondary outcome measures, we saw that in terms of number of adverse events, length of stay, et cetera, et cetera. The sooner that we intervene, biologically, it seems to be better. And we hope that there will be greater adoption of intracerebral hemorrhage evacuation using these techniques across the board. But we'll have to wait for the committee from American Stroke Association to reconvene for the next version of the guidelines, which will be in a year or two, and see what they judge the results of the trial to be and how they want to incorporate it into the guidelines for management.
Yeah, to add to that point, Gustavo, about the ability to apply the surgical technique at other centers, I think that one of the things that was most interesting from our data is that of the 150 surgeries that were done, it was done with 59 unique surgeons. And so it's a wide gamut of surgeons that participated in this trial. It wasn't just, you, Gustavo, who's done a multitude of these cases. It was everybody that had some experience, but again, a really vast number, which is pretty cool to see that it's about the surgery, not just the surgeon in this case. Well, I have a question for my team. Gustavo and Alex, do you guys want to comment at all on the applicability of other devices and whether just this supports the idea of a general minimally invasive approach or if it is device specific?
It's a great question because we had two preceding trials that were done with a very good intent, a very good design and by very good teams in the past. The stitch trials were conducted using conventional craniotomy techniques. And unfortunately, that study was negative and has been scrutinized at length, so we don't have to discuss it. And the same goes for the MISTY study. And it was also a very well-conducted trial done by great teams with a different methodology. So I think we have to infer that the results have to do with the integrated approach. Now, there are newer devices coming into the market that have a similar philosophy of a small footprint, respectful of white matter structures, and that provide the right surgical tools for access. And I think they're going to have to be tested in the same rigorous way as we tested this technology to be able to confirm its applicability. But I think it definitely settles the question of whether open versus minimally invasive approaches and which one is better. And I think clearly we have the first trial that defines minimally invasive surgery as being superior to the results achieved with conventional surgery in the past.
Yeah, and I think from looking at historical precedents, especially in the thrombectomy world, that technology will always get better, as it seems. I'm looking at since the 90s up through the 2000s, how devices got better and changed. I think one hope is that with seeing some positive results from this leads to more innovation across device manufacturers. I mean, and I think that they could get better and safer potentially. There are just things that I don't even know may come about, but I do think we certainly saw that in the endovascular space. The technology just keeps getting better and better and better, even from the same companies that were originally manufacturing from the beginning. They just continue to improve devices, which of course at hospitals and institutions we don't have the ability to do that. So it's really some of those industry leaders that improve those things. I think it's important to highlight that this was an academic and industry partnership. Our funder and sponsor was the NICO Corporation. And from the beginning, they put a lot of trust into us and the scientific leadership team in funding this. We really went into this telling them this is more of an academic mission behind the trial and what we want to try and do. And they really allowed us to maintain that and throughout the trial and stuck with it over 7 years in the COVID pandemic and other things where I'm sure funding is always tight everywhere. So, we're certainly appreciative that the company was able to fund this and actually complete this in trial for the patients in the field.